University, Bangkok, Thailand. First of all, I would like to thank the organization committee for having me here. Today, I will talk about clinical presentation and diagnosis. I think Dr. Kyoto already speak very comprehensive review about chronic constipation. So I will talk about the case. So let's begin with my case. So this is 30 years old Thai female has recorded constipation for the past 10 years. She has a bowel movement frequency of 2 times per week with small stool quantity. So the question is, what is her meaning of when she reported constipations, and do you think that the patient's perception and our perception, is it the same? So let's go back to our criteria. I think all of you know that very well. So for the local criteria, we know that there are 6 key constipation symptoms that we need, 2 at least, to be diagnosed as functional constipation, which is straining, hard stool, incomplete evacuation, anorectal obstruction, manual maneuver, and infrequent bowel movement, which defined as less than 3 spontaneous bowel movement per week. When you speak about the stool, when you talk to patients, it's difficult to describe, how is your stool consistency look like? Better to use the chart like this, Bristol stool form scale, so let them choose actually what is their stool consistency. So we can use this to adjust the treatment as well. And moreover, this Bristol stool form scale also can estimate the colonic calcium count. So this is the study from Western countries that show that if the patient has Bristol stool form scale less than 3, will predict delayed colonic calcium. However, for the stool frequency, there are no correlation with the delayed colonic calcium. There are also data from our center that we try to see the association between stool form and stool frequency and colonic calcium. We found that stool frequency less than or equal to 2 and Bristol stool scale less than 3 or equal to 3 could use as a surrogate for delayed colonic calcium in recent patients with constipation. So in my opinion, better to ask whether what is your stool consistency look like. Then move to the perception. This is the very nice study. It includes 3,000 patients that they ask patients to do the questionnaire whether what is the key diagnosis of constipation in terms of patient perspective. And you see the general population, less than 50% they consider our long four criteria is important. So let's see straining, hard stool, incomplete evacuation, manual maneuver, or infrequent bowel movement. Less than 50% of patients think that actually this is a constipation. And some symptoms, for example, incomplete evacuation, manual maneuver, even specialist doctors, just 30% consider this is important to diagnose chronic constipation. So, is inconsistent agreement between perception of diagnosis constipation and local criteria as well. You see the patients who self-report constipation and also have been diagnosed according to local criteria. What is the thing important? The thing that this is top 5 symptoms that they consider important. First is straining. Yes, we all agree with this. Second is the need to use of laxity, which actually never write down in any part in the local criteria. Third one is the hard stool, and fourth is protein. Last one is long time on toilet without bowel movement. You will notice that not only constipation symptom is important, but bloating or abdominal symptom is also another symptom that patients consider important and disturbing. When we ask about what is moderately or severely bothersome, in general population, they consider training is important, but also abdominal discomfort and bloating also important symptoms that they consider bothersome. So not focus only on constipation symptoms, but we also have to focus on other associated symptoms, including bloating, distension, and pain. Moreover, so we have to also emphasize whether these patients have any alarm features or not. For example, weight loss, breathing, or family history of colon cancer. So we have to exclude secondary causes, including obstruction, medication, systemic illness, especially patients who have a new onset of constipation. So go back to our case. So I asked more detail about what do you mean by constipation, and this is her history. So she had bowel movement 2 times a week with hard stool and typhoid, so the scale type 1, small stool quantity, incomplete evacuation, and also occasional use of manual maneuver. She also experienced bloating, which is actually bothersome, but deny any alarm feature. So do you think what is the physical examination that we should focus on these patients? Yes, so according to Dr. Ki, so we focus on the distal rectal exam. I think before 10 years ago as a GI fellow, I never considered this is important, but now I believe it's important. Not only inspect inside to see what happened, it's not just anatomy, but also the physiology. We can explore whether is there any abnormal anorectal function or not. We ask patients to do a squeezing maneuver. We ask patients to push and bend down maneuver. So for this maneuver, we have a good sensitivities and specificities to diagnose difficult disorder. So in this case, I do a distal rectal examination, and this patient show a very good pushing effort. However, anal sphincter didn't show any relaxations. So, what do you think? What is the most likely diagnosis in this patient? So, in my opinion, right now, from her symptom, she has a symptom that compatible with the functional constipations. And sometimes she also have experienced bloating symptoms, which now not considered fit with Rome 4 criteria, but previously, if we use Rome 3 criteria, bloating may be considered as other symptoms. And when we do a distal rectal examination, we know that she may have functional defecatory disorder together with functional constipation. So the pathophysiology of functional constipation in this patient may be caused by functional defecatory disorder. So this is the law 4 criteria between functional constipation and IBS-C. So I would like to emphasize that the IBS-C, they're going to be abdominal pain predominant. This is from the law 4 criteria, but in our center, we found that the pain is not a major concern. The most bothersome symptom actually is bloating, which is actually removed out of the law 4 criteria. So if patient complain about bloating, we still consider that this is important symptom that we need to focus on. Next, because her distal rectal examination show the unable to relax her sphincter, so we suspect whether she has a functional defecatory disorder or dyslexic defecation, or other term is dyslexia. So actually it is a behavioral evacuation disorder, which is discoordination between abdominal muscle and pelvic floor muscle. To diagnose this, patient needs to satisfy diagnosis criteria of functional constipation and or IBS-C, and we need at least 2 out of 3 tests. First, abnormal balloon expulsion test. Second, abnormal anorectal evacuation pattern with anorectal manometry or surface EMT. And lastly, abnormal rectal evacuation by imaging, which can be done by decryptography or MR decryptography. So in summary, The diagnosis of functional constipation should be made using the following 5 key features. First, history. Try to ask whether actually do we speak in the same page or not, because the meaning may not be the same between doctors and patients. And physical examination, we should do rectal examination. We limit the use of laboratory tests, especially patients who don't have any clinical clue of specific systemic disease. Colonoscopy should be done if patients have a lung symptom. And specific tests to evaluate constipation pathophysiology should be done if patient consider refractory constipation. So this patient, despite lifestyle modifications and adjustment of laxity, she still experienced symptoms. So right now we consider as a laxative failure or refractory constipation. Even right now, the definition of refractory constipation is still debated. So it depends on guideline to guideline. Some guidelines may mention that if you fail laxative, we use laxative for 12 weeks and is not no response, we consider as refractory. So we will start to do the anorectal manometry together with balloon expulsion test. If it's abnormal, both tests, so now we consider this patient have defecatory disorder, which all guidelines recommend to do biofeedback therapy. But if the first 2 tests is inconclusive, let's say if manometry show dysynergia pattern, but normal balloon expulsion test, so you need to do more tests, which is depthicography. Can be just standard depthicography or MR depthicography. If all normal, now we consider doing chronic transit study. If it's abnormal, so the pathophysiology of constipation in this patient will be a slow transit constipation. So anorectal physiologic study will determine the pathophysiological mechanism. And symptom alone is a poor predictors of underlying pathophysiologies. So this is the study from our center in Thai patients. So we study patients who have idiopathic constipations, and we found that 30% of patients have this dysynergia pattern, and around 20% have delayed colonoscopy transit. And we also note that symptoms cannot predict or cannot discriminate between dysynergia and other causes of chronic constipations. Only infrequent bowel movement was associated with delayed colonic transit. So this is her anorectal manometry testing. You will notice begin with this. This is pressure band, lower band is the sphincter, and upper band is the rectum pressure. So you ask patient to bend down, you will see the patient try to push, and the upper sphincter and the rectal sensor. I'm not sure if you can. This band is rectum pressure, so this is patient pushing, and this is sphincter. So you notice that this patient cannot relax her sphincter. So we do it 3 times and no relaxation. So this is the anorectal manometry finding. So we consider she has a good propulsion with paradoxical anal sphincter contraction during lying down, and her sensation also abnormal, and consider as a rectal hyposensitivity because she have S1, which is the sensation that something inside the rectum at the balloon field with air field at 80, and S2, which is urge sensation at 120 and don't have any interval urgency. So this considered as rectal hyposensitivities. With abnormal balloon expulsion test, so she will fulfill the diagnostic criteria as functional defecatory disorder together with rectal hyposensitivities that the treatment after failed laxative will be biofeedback therapy. And this is the data of biofeedback therapy in this allergic defecation patient with and without irritable bowel syndrome in our center. So it's 30% or 60% success that most of the patient can stop laxative. So in conclusion, perception of constipation may differ between patient and physicians, and digital examination is the key to evolve dysynergia. anatomical physiologic studies indicate for refractory cases. Thank you for your attention.